Hi everyone, welcome to this video. In this one, we're going to be talking about iron studies. All right, before we jump into it, a little icebreaker, tell you a little bit about my medical school experience with iron studies. So in 2001, this is me after my white coat ceremony. I was very happy and excited. And in 2005, this is me after my long white coat finally was achieved, and I was very, very happy and excited there. But somewhere here between 2001 and 2005, I remember that I repeatedly had to study this table from first aid, which interpreted the iron studies. And it was very difficult because I didn't learn it quite well. And I was always trying to memorize it and apply it. And every time I had a question, I would struggle. And therefore, I was very sad. And so what I'm going to hope to do by the end of this video, because this is a common feeling that many medical students have when they have to deal with the challenging questions related to iron studies, is that by the end of this video, we're all going to be very happy and very, very much smiling and excited. And we're going to look forward to seeing iron studies and the cases as they come up. All right, let's start with our case. We have a 24-year-old woman who's presenting to the clinic for fatigue. Past medical history is significant for RA. Unknown last menstrual period because the patient has chronic irregular menses, and the labs show us that the patient is anemic right here with an MCV of 74. Iron studies are shown below. Which of the following is the most likely diagnosis? So we will revisit this case at the end of our lesson. We will go through each of these choices and answer the question. So here's a quick outline of our talk. We're going to start with talking about why do we do iron studies, how do they help us clinically. Then I'm going to explain to you what exactly we mean by an iron study, what are we testing. Then there are 2 rules that you need to know before we look at the cases. And then we're going to talk about the 3 states of the iron studies and go through the iron table for each of the states. All right, so let's start with indications. Why do we do iron studies? Well, they basically tell us what the patient's iron status is, if it's normal, low, or high, and there are primarily 2 main indications that we clinically have for this. First one is anemia. So when a patient comes in with anemia, iron studies are extremely helpful in identifying the cause. For example, is this iron deficiency or some other cause? And especially I have to highlight that in people with microcytic anemia, so if you get that MCV and it's low, the very first test you really should be doing to evaluate it further is going to be iron studies, because that's going to help you if this is iron deficiency anemia, thalassemia, sideroblastic anemia, anemia of chronic disease, all of these that are listed here as the common disorders. These are all part of the microcytic anemia algorithm. But also in normal and macrocytic anemia, sometimes patients who have anemia from another cause that falls in this bucket may also get a secondary iron deficiency. So it's generally a good idea in anyone with anemia to obtain iron studies. And finally, you can have the opposite problem. So you can have an iron overload state, such as in hemochromatosis. And so again, the way you would make that diagnosis or be geared towards that is by getting these iron studies. So these are important clinical reasons for the iron studies. All right, so what exactly is an iron study? What do we mean when we say we're getting iron studies on someone? So it's real simple. We're basically just measuring 4 things in the serum. So here's what I want you to take away. There are 4 things we're measuring right here, as shown here, and they're all in the serum. They're all in the blood. That's what we're measuring. What are the levels of these things inside of the patient's serum? First one is the serum iron. So how much iron is present in the blood? Now, confusing thing. Everyone always thinks that this is free iron just floating around in the blood. That's not true. This serum iron is literally measuring how much iron is in the blood bound by transferrin. Remember, iron in the blood is never free. If it was free, it could cause Fenton reaction. It could cause damage. So iron in the blood is bound by transferrin. So what this is actually measuring is how much iron is present in the blood, and all of that is bound by transferrin. So it's also kind of measuring how much transferrin in the blood is bound by iron. Next one is something called a TIBC. This stands for total iron binding capacity. This is essentially indirectly measuring how much transferrin you have in the blood. There are a couple of proteins in the blood that can bind iron. For example, a little bit of ferritin is also present in the blood, although most of it is intracellular. But really, the main thing that TIBC is measuring is the transferrin levels in the blood. And so when you see TIBC, just equate it to transferrin. So what TIBC is saying is how much total transferrin is in the blood, and this is measuring both the free and the bound to iron. So people get confused because it says total iron binding capacity, and they think because it says binding capacity, it's only talking about free transferrin. That is not true. TIBC is talking about total transferrin, how much free and bound to iron transferrin you have. So this is your total amount of transferrin in the blood. Next is percent saturation. So what percent of this total transferrin that you just measured is bound by iron that you just measured up here? So it's essentially, this is the ratio of transferrin bound by iron, which is essentially what you're getting in number 1, over total transferrin, which is what you're getting in number 2, and that is your percent saturation, which is right here. And the last thing is ferritin. So ferritin, remember, is the main intracellular storage form of iron. So what this is checking for, though, is how much ferritin is in the blood. That may be a little bit confusing because you're thinking, well, but ferritin is mostly inside of the cells. What happens is that as ferritin levels inside of the cells go up, then the amount inside of the blood goes up and vice versa. So essentially you can use the blood levels of ferritin as a reflection of how much is intracellular. So even though we're measuring in the blood, it's essentially telling us, the ferritin is essentially telling us how much storage of iron we have inside of our cells. So these are the parameters that we're going to be measuring in iron studies. And now I'm going to move on to talk about the important rules to keep in mind. All right, so now let's talk about the two golden rules, because I feel like if you apply these rules right off the bat, if you just think about every case in this way, it's going to make going through these iron studies so much easier. So the first rule is that ferritin depends on the total stored iron, not the serum iron levels. I'm not saying anything controversial here. This should make sense. Ferritin is the intracellular storage form of iron. It's the protein that binds iron inside of the cells, and therefore whether its level is going to go up or going to go down should depend on the total amount of stored iron inside of the cells, not the serum iron levels. That's number one. The second thing is that transferrin levels are going to go in the opposite direction of ferritin. So just keep that in mind. If the ferritin levels are going up, the transferrin levels are going to go down. If the ferritin levels are going down, the transferrin levels are going to go up. These are the two golden rules to keep in mind. And let me show you an example of how this plays out and why this makes sense. So imagine that the iron stores inside of the cells are high. So what that's going to tell the body is increase the ferritin levels because we need more storage to keep up with these intracellular amounts of iron. And then at the same time, transferrin levels are going to go down, not just because I said up here that it's going to go in the opposite direction, but physiologically that also makes sense because the cell is going to say, hey, stop transferring or bringing iron to us because we're already filled up with iron. So the consequence of this ferritin going up is decreased transferrin, and that all makes sense with the underlying issue that caused all of this. Now let's look at the opposite situation. Iron stores are low, so you have low levels of iron inside of the cell. Therefore, you're going to need less storage, so you're going to bring down the ferritin levels. And on the other hand, transferrin, again, is always going to go in the opposite direction. So transferrin levels are going to go up because you're going to want to deliver or transfer more of the iron from the blood into the cells because the intracellular levels were low, and this should also make sense as well. So key takeaways, ferritin depends on the total stored iron inside of the cells, not the serum iron, and transferrin level is going to go in the opposite direction of whichever way ferritin went. If you keep these in mind, it's going to be a piece of cake. All right, so now let's start looking at the iron studies table. So here now we have the our 4 parameters up here, and we have our 5 commonly checked for disorders, and here are what the variables are going to look like in each of these. So what's going to go down, what's going to go up, and you can see just by looking at this how this can be a little bit overwhelming and intimidating. It's a little hard to, are you going to memorize all of this, or are you going to try to find a pattern? It gets a little bit difficult when you look at it in this way to try to figure out what's going on. So here's my recommendation, and here's how we're going to approach it. We're going to break down this table. We're going to break down these 5 rows into different iron states. And based on that, we're going to actually explain what each of these values are going to look like. And it's going to be very, very simple if we look at it this way. So the way we're going to do this is we're going to break these 5 rows into 3 different iron states based on what's actually going on inside the body with each of these states. And then we're going to be able to explain what each of these findings are going to be. And so we're going to start doing that right now with the first state up next. All right, so the first state that we're going to go through is the low Fe state, the low iron state, and the main disorder that falls in this category is iron deficiency anemia. So that's the only one of our 5 disorders that's going to fall in this category, and it's shaded here. So in the low Fe state or the low iron state, obviously the problem is too little iron inside of the body. That's what it means, and this can occur because you have too little intake or absorption of iron, or you might have too much iron use or loss, for example, through blood loss. But whatever the cause is, the problem is going to lead to iron deficiency anemia and too little iron in the body. So now let's talk about what the iron studies are going to look like here. And this is going to be very straightforward. You have too little iron in the body, so you're going to have low levels of iron in the blood. That makes perfect sense. Therefore, the serum iron is going to be low, and that is shown right here. Very easy. For the same reason that you have too little iron in the body, you're going to also have low total iron stores inside of the cells. Remember, those iron stores are made up of iron bound to ferritin. Therefore, the ferritin level is also going to be low, and that is shown right here as well. Again, very straightforward. And now moving on to number 3, transferrin. So the transferrin is going to be high. Remember, one of our golden rules is ferritin and transferrin is going to go in the opposite directions. So if ferritin is going to be low, transferrin is going to be high, and therefore your TIBC, which is essentially the measure of your transferrin, is going to be high, and that explains that one right there. The final piece, which is the percent saturation, number 4, that's just a ratio. That's just a calculation of your serum iron bound to transferrin, essentially. So this is a measure of how much transferrin is bound to iron. This is a measure of your total transferrin. So you get the ratio of that, and that is the percent saturation. And obviously, this is going to be very, very low because you have decreased your numerator, increased your denominator. So therefore, you're going to have much less transferrin bound to iron. So the percent saturation is much lower. And this explains the iron studies in somebody with a iron deficiency anemia. All right, now we're going to completely flip it. We're going to go from the low iron state to the high Fe, or the high iron state. And this one is actually going to cover the next 3 disorders that are in our table. These are all shaded blue right here: hemochromatosis, thalassemia, and sideroblastic anemia. So all of these are high iron states. And what does that mean? That means that in all of these, there is too much iron in the body. So this is literally the opposite of the previous state, the last one where we talked about iron deficiency, where there was too little iron in the body. So before I explain to you the iron studies, let me just explain to you why these 3 states cause too much iron in the body. The first one is hemochromatosis. That's actually the disease itself. It's in the name. There's a separate pre-work video today that talks about that, so you should watch that. But in a quick nutshell, essentially this disease, especially the hereditary form, you have a problem with homeostasis of iron. Therefore, you essentially end up accumulating too much iron inside of the body and can't get rid of it. And therefore, this causes hemochromatosis, excess iron in the body. In sideroblastic anemia, so how does sideroblastic anemia cause excess iron? Well, remember here we have a deficient enzyme, so you can't convert iron to heme, and therefore this is going to lead to excess accumulation of iron by itself, and this is how you have too much iron inside of the body. And now in thalassemia, how does this cause excess iron? Well, one problem is that you have less globin, therefore you're going to have more unused heme and iron, therefore this is going to lead to the accumulation of iron. And the second problem is that many patients with thalassemia, especially the ones with thalassemia major, are actually dependent, their life actually depends on getting frequent red blood cell transfusions to be able to maintain their red blood cell levels. And so every couple of months, these patients get bags of blood. They're also essentially getting bags of iron. And as those red blood cells are hemolyzed and die off, the iron is going to continue to accumulate inside of these patients, and they're going to have higher levels of accumulated iron. So these are the reasons why these conditions are all iron overload states. But regardless, the main thing to recognize for the iron studies is that all 3 of these are high iron states, too much iron in the body. So now let's talk about what the iron studies are going to look like. So the iron level in the blood is going to be high. This is going to be very straightforward. There's too much iron in the body, so too much iron in the blood, so serum iron levels are high in this case. For the same reason, since there's too much iron in the body, there's going to be high total iron stores inside of the cells. Again, this is an iron overload problem. So the ferritin levels, which are the indicators of intracellular iron storage, are going to be high. And as you can see here, ferritin levels are high. And by now you know that if ferritin goes up, transferrin comes down. It's the opposite. So this is going to lead to low transferrin levels. And so these patients are going to have a low transferrin or low TIBC right here. And so the last thing to figure out then is going to be the percent saturation. So remember, the percent saturation is how much of the transferrin was bound to iron, which was right here, and that went up, over how much total transferrin you have, which is over here, which is what went down. So therefore, the ratio of these is going to be greatly elevated, indicating that the amount of your transferrin that is saturated has gone up, and therefore the percent sat has gone up. And this is the explanation for the high iron state. If you were to take a quick glance at this, you would actually notice that every variable of these 4 is the complete opposite of what we saw in the other state, the last state, and that should make perfect sense because the last one was a low iron state. This is the complete opposite, which is a high iron state. So every value here is going to be the complete opposite of the other one. All right, so our last 2 states were pretty straightforward. Iron deficiency, the parameters made pretty good sense. The iron overload made pretty good sense. It was the opposite of the iron deficiency. Now we're going to come to the tricky one right here, and this is what I call the what the FE state, because it's like, what is going on in this state? This one's a confusing one. This one is tricky. But when we go through it together in this slide, after I explain a couple of these things, it's actually going to make perfect physiological sense. You'll be able to figure this out, no problem. So this one is caused by anemia of chronic disease. What's the problem with anemia of chronic disease? Hepcidin. You have too much hepcidin as a consequence of the inflammation. What does hepcidin do? Hepcidin keeps the iron hidden inside of the cells. So the problem here is you have too much iron being trapped inside of the cells. Can't get out. So what's going to happen here? Well, iron's trapped inside of the cells, can't get out, can't get into the blood. So your serum iron levels are going to be low because it's stuck inside of the cells. Easy peasy. Next one, your total iron stores. total iron stores here are going to be high even though the blood levels are low, because remember the problem is trapping iron inside of the cells. That was our number one problem. So if there's too much iron stores inside of the cells, that means that the ferritin levels are going to actually be high in this case. So you can see high ferritin. Even though you have a low serum iron, you have a high ferritin. This is the first time we're seeing a disagreement between these two, and that's okay because that's the pathophysiology of this disease. That's why it happens. The rest of this is pretty easy. You have low transferrin because you remember the golden rule that it's going to run the opposite of ferritin. So these cells are saying we have lots and lots of intracellular ferritin bound to iron already. We don't need any more transfer to us. Bring down the transferrin levels. And so transferrin is going to go down. Just like always, it's going to run opposite to ferritin. And so the TIBC is going to be low. And so the final part is the percent saturation. And this one, you might see it sort of stated differently in different tables. A lot of places just say this is normal, and that makes good sense because you're going to have a decrease both in the amount of saturated transferrin bound to iron as well as your total transferrin. That's going to be normal. Some places say that it's going to be a little bit on the lower end of normal or low because the serum iron is usually a little bit lower than the amount of decrease in TIBC. That distinction doesn't really matter as long as you recognize that the only one of these where normal can be an option is anemia of chronic disease because of this ratio that you're seeing. Should make perfect sense. And as long as you understand that this can't be elevated, you're good from that standpoint. And that is the description for anemia of chronic disease. It's important to recognize that the pathophysiology is the reason why you have a difference in the serum iron levels from the ferritin levels. Once you get that part figured out, everything else is straightforward. All right, so now since you all are so exceptionally smart, I decided to throw one more thing in here for you. And I didn't decide that, but you have to know this. It is fairly high yield to know. So I just decided that once you've got this table down, this is a good time now to introduce the one final state, because now you know what the rules are supposed to be. So now I can tell you what is this one final state, and this is the last thing that you need to know for the iron studies at this stage. And this is called the increased estrogen state. So when does this normally happen? This normally happens in this last row that I've added to the table. So in pregnancy or combined oral contraceptive pills, right? So under these conditions, you have more estrogen than normal, and increased estrogen actually leads to higher transferrin expression independent of iron and ferritin. So what does this mean? That means that the body is just going to produce, express, and make more transferrin proteins. Not going to change anything in the iron, not going to change anything in its ferritin levels. Just going to make more transferrin. And there is actually kind of a physiological explanation about this if you think about it. In pregnancy, what's going to happen? The body's going to start getting used to having to use up more of the iron, right? So it's going to want to increase its transferrin levels to have the capacity to meet that excess iron demand and be able to improve iron transfer to all these extra cells that need it. So physiologically, it makes sense that it would do that. The key here, again, recognize higher transferrin expression independent of iron and ferritin. So if you know this, then you know exactly what these iron studies are going to look like. Serum iron is not going to change because I just said this has nothing to do, this is independent of serum iron levels, so there's going to be no change in the iron levels in the blood. Serum iron levels are unchanged. There's also going to be no change in the total iron stores. Remember, this is the amount of iron stored inside of the cells, and that's all determined by ferritin. And again, I mentioned it here earlier, this is independent of ferritin, so there's no change in the ferritin levels. So what's happening is a high transferrin. That was what was going on, but that is the underlying cause of all of this. So there's an increase in transferrin expression. Therefore, the TIBC, aka transferrin levels, are going to go up. And the last thing to recognize is the percent saturation, and that should be very easy for you to be able to calculate. The total amount of the saturated transferrin did not change because you didn't have any more iron, but your denominator went up because now you have more transferrin capacity, therefore the percent saturation is going to go down. So the key iron studies finding in pregnancy or oral contraceptives is no change in iron and no change in ferritin, with an increase in TIBC and a decrease in saturation, and this is the final piece of the iron studies that you need to take away. All right, so now let's summarize everything that we learned about iron studies, and I'll give you a couple of helpful tips on how to approach a question that comes in that's related to iron studies. So here's our table and our parameters. As a reminder, ferritin is the total body iron stores, how much is inside the cells. So a helpful tip here is when you get a question and you have these iron studies, the first two parameters I would look at are the serum iron and the ferritin. And this can help you quickly narrow down what is the patient's iron status and which one of these four is going on, as I'll show you right here. So in case one where you have a low total body iron, as shown here in iron deficiency anemia, both your serum iron and ferritin are going to be low. So if you have low serum iron and low ferritin, they're both low. The only thing that this could mean is that you have low total body iron stores, and iron deficiency anemia is the only cause. So this helps you quickly narrow it down. Furthermore, if you take a look at this table right here and just look at the ferritin itself, you'll see that the only cause on this table that has low ferritin or decreased ferritin is iron deficiency anemia. And this is pretty much the only thing that causes decreased ferritin. So if you just see a decreased ferritin in your lab values, you pretty much know that this patient has iron deficiency anemia. And this is a fact because ferritin is a very sensitive indicator. And in fact, serum ferritin levels go down or decreased even before the serum iron levels are decreased in iron deficiency anemia. So this is a very helpful hint. Now moving on to condition 2. So these are the conditions with the high total body iron stores. So again, you can see that the serum iron and the serum ferritin are matching, but in this case, they're both high. So they're the opposite of what we saw before, which makes sense. So both serum iron and both serum ferritin are going in the same direction, except here they're both going high, which makes sense because this is the high total body iron, and this can quickly narrow down your case and your diagnosis on your question to a condition that falls in this category. Now moving on to number 3, where you have the anemia of chronic disease, and the problem here is that the iron is trapped inside of the cells. So now you have something new. By simply looking at the serum iron and ferritin, you can see that now there is a discordance. The serum iron is low, whereas the ferritin is high, and this is because iron is trapped. Therefore, you can see that this is different than the other two, and the only cause on this table that causes this discordance between the iron and the ferritin, where one is low and the other is high, is anemia of chronic disease. And therefore, again, by looking at those two parameters, you can quickly narrow it down to here. And finally, the last one, the high estrogen state, as we saw here with pregnancy or oral contraceptives. So here, your serum iron and your ferritin are both normal. So now you're thinking, okay, well, how do I know that this is not just a patient that has normal iron studies? Well, this is normal iron status essentially, and this is where you have to go beyond these two, and you look at the transferrin and you see that the transferrin is high. You go, aha, this is the underlying problem here. This is the underlying cause of the anemia or the iron changes here in pregnancy, and therefore based on this, now you can see that here this breaks the opposite rule. The opposite rule was that when transferrin goes up, ferritin goes down. But remember, this is independent, so you have a high transferrin and a normal ferritin, and the only condition that causes this is high estrogen levels. So this is just a helpful way to help you approach the questions, especially as you're studying for exams related to iron studies. You'll see when you do your clinical rotations that there will be more nuances when you're interpreting them in actual clinical practice. But for your current expectations and for studying for USMLE exams, this will be a great start on how to approach these questions. All right, so now let's wrap it up. Return to our case. Remember, we have a 24-year-old woman who's coming in for fatigue. Past medical history is positive for RA. LMP is unknown because the patient has irregular menses chronically, and the patient's lab reveal anemia with an MCV of 74. So what does MCV of 74 mean? If it's less than 80, that means it's microcytic. So far we know this patient has microcytic anemia, probably why she's fatigued. We also know she has RA, and we don't know when last menstrual period was. Iron studies are shown right here, so that means we probably have to interpret them, and which of the following is the most likely diagnosis cause of her symptoms. So in a situation like this, with this kind of a question, I would look at the iron studies first and try and interpret what state iron study does this patient have, which one of the states that we talked about, and then look at our answer choices and figure out which one matches the iron studies. So let's start doing that. Looking at our iron studies, remember I said the first two things we look at is iron and ferritin. So patient's iron value right here is 45. That is lower than the normal provided here. So this patient has a low iron level. And ferritin is 5. Again, that is lower than the reference range. So the patient has low iron and low ferritin. And as you already know, if somebody has low ferritin, especially confirmed with low iron, that patient has iron deficiency anemia. So we know that that is what we're dealing with in this patient. We can further confirm it by proving that this patient's TIBC is high, as shown here, and percent saturation is low. So all of these parameters are again confirming that this patient has iron deficiency anemia. So now let's look at our answer choices and see if we can eliminate, and what are we going to land on. So thalassemia, well, that could be tempting because a patient has microcytic anemia, but of course remember that thalassemia would give you an iron overload state, so you would have the exact opposite parameters on your iron studies, so we eliminate that. Pregnancy could be tempting here given the patient's age and unknown last menstrual period. You always have to consider pregnancy. However, in a patient with pregnancy, remember that your iron studies, your iron and ferritin would be normal. Therefore, this does not fit this category either, so we can eliminate that. And now we're left with these two choices. Chronic disease is tempting because this patient does have a known history of rheumatoid arthritis, and that might be what you're leaning towards. Except remember that if somebody has anemia of chronic disease, that is the condition where the iron studies, the iron and the ferritin would be discordant. That means serum iron would be low, but ferritin would be high. But here you don't have that. Both values are low. So you eliminate chronic disease as well. So you're left with blood loss, which in fact, chronic blood loss does lead to iron deficiency anemia, and therefore these two match right here. So this patient probably has chronic blood loss, perhaps due to her chronic irregular and maybe heavy menses, which is causing her symptoms, her microcytic anemia, and the lab findings, and that is our final diagnosis, and the correct answer is A. All right, so that's the end of this module. I've included some links to some videos that are relevant to this topic if you're interested. Thanks for watching, and we will see you next time.